Good morning, Your Excellencies, distinguished guests, dear colleagues. It's an immense privilege to chair this very important plenary, Health in the Post-2015 Development Agenda. This is a major landmark, not just for health, but for sustainable development globally, as we build on the successes of the MDGs and move beyond health to address not just health outcomes and poverty, but all the social determinants that are the causes and the consequences of poverty and the problems that follow poverty. To discuss this very important issue, we have an incredible panel. Very distinguished panelists, starting with Mark Dybul. Mark is Executive Director of the Global Fund, and he has been instrumental, not just at the Global Fund, but also in his previous role at PEPFAR to really transform the HIV response globally. Then we have Freda, and Mark is going to talk about health in the changing landscape of health, global health with the new development agenda. Then we have Freda Lewis-Hall, the Chief Medical Officer of Pfizer. And Freda will share with us her views and the view from the private sector on how the private sector is going to contribute and engage as partners in the new development agenda. As you know, Pfizer and other major pharmaceutical and medical technology companies have contributed greatly to MDG 8, but also beyond that to expand access to many valuable medicines and health technologies. Then we have Nedret Emiroglu. Nedret is the special representative of the Director General of the WHO European region, Susanna Jakob, previously for MDGs and now, as of 2 weeks ago, for SDGs. And Nedret is going to share with us how does the governance shape? What will it look like going forward? And what is the role of agencies such as WHO that have the mandate for health within this broader development agenda? Then we have Debra Jones, who is Director of Save the Children International. She's also the representative at the United Nations for Save the Children. She will talk about the response of organizations such as Save the Children for SDGs and health. How we move from concept to implementation to delivery, actually what matters. And then we have Dagfinn Hoybråten. Dagfinn is the chair of the Gavi Alliance, another important institution that played an instrumental role in expanding access to immunization and impacting on under 5 and infant mortality globally. Dagfinn will remind us, as we have the SDGs, an important agenda, we still have an unfinished agenda. How do we reach that lost child, that 20% that remain, the poorest segments, the disenfranchised? So he'll remind us that there's an unfinished agenda, there's an equity agenda to be addressed going forward. It's a real privilege and pleasure to invite Mark. Each of my speakers are going to speak for 12 minutes, but I know that will go to 15. So we'll have another 15 minutes or so at the end for questions. Thank you. Mark.
Thank you, Rifat. And just to be clear, we were told 15, so we weren't told 12. But smart move. And I hope slides will be coming up at some point. Yes? I want to begin by thanking the hosts of this and patrons of this meeting at the World Health Summit. It's a privilege to be back in Berlin. Chancellor Merkel from Germany, President Hollande from France, and President Juncker from the European Commission, 3 huge supporters of the Global Fund, and really some of the leaders in pushing us forward in health. So the title of this talk is The Changing Landscape of Global Health and Development, Exciting, Challenging, Possibly Frightening Time, and the stuff that makes the stuff of innovation. So as Rifat mentioned, the SDGs were adopted by the world not long ago, a few weeks ago, and the goal 3 is ensuring healthy lives and promote well-being for all at all ages, which is a great chapeau, but then there are a lot of targets below, including one specifically related to ending the epidemics of HIV, TB, malaria, and neglected tropical diseases, combating hepatitis, waterborne diseases, and other communicable diseases. Long. I think what's really important is the chapeau of all the SDGs is actually challenging us to stop focusing on individual issues and focus on people, and that's something that we'll talk a little bit about. So entering this, I think it's important to acknowledge that the landscape has radically changed over the last 15 years since the MDGs were adopted. The epidemiology has changed dramatically and will continue to change of the diseases, and we'll show some of that. Importantly, low-income countries and middle-income countries are growing in relative importance and are actually significantly increasing their own contributions, meaning that official development assistance, and just the words we use, assistance is actually an offensive term to people in Africa and other places. It's actually support and partnership, has limited and perhaps relatively short lifespan, changing models. We have increased institutional capacity and really a requirement that people in the country take the lead. Private sector and civil society is changing their roles. And importantly, a new political landscape, which we'll talk about. And that really leads to a very, very different time. In fact, this is probably the most exciting time, in my view, to be involved in global health and development because we are seeing radical shifts we have never seen before. Before we pushed everything, for the last 15 years, we've basically been pushing everything through the models we had for 50 years. Now we're going to need new models. So this is a notional direction of where things could be going. In the red line on top, you see a decline over time of, and I have no idea if this is going to work, probably not, decline over time of external financing, which can come through multilaterals, bilaterals, whatever mechanism, as domestic finance in yellow is increasing. But we're also going to see new players, new emerging powers that don't particularly like the ODA model. And we're also seeing new innovation's a bit redundant. We're seeing innovation and change and an information exchange that's radically different. So over time, you start to see a change in the entire landscape. Now, individual countries will go along those red and yellow lines in a different pace, depending on who and where they are in their development. But we will see this type of pattern occurring over time. Something that's driving a lot of this is the change in income in countries. If you look to the left, you see low-income countries, and to the right, upper-middle-income countries. The green line is where countries were plotted against GNI in 2005. Just 7 years later, and this isn't country to country, see the shift up to the blue. What you see is a significant growth in GNI, and all those countries circled in red change classification from low to low middle or from low middle to upper middle, which is a huge change. And I think many of you have seen that is expected by the end of the SDGs. Only 15 to 20 countries will still be low-income countries, which is where we focus most of our effort so far. And you have a very different approach in those countries probably than in low, middle, or middle-income countries. However, this shift hasn't led to a great deal of equity. You probably saw this week that the World Bank reported that we have under 10% of people living in poverty. Unfortunately, most of those people live in middle-income countries, and the poverty line, as you can see, is $1.25 US per day. Hardly a great place to be to say someone's been lifted up out of poverty. But the majority of people, 70% of people living in poverty, live in middle-income countries. And in fact, the majority of HIV, the significant majority of HIV, is now in upper middle and upper middle-income countries. TB always has been. 80% of TB is in middle-income countries. In fact, 70% of it is in the BRICS. And MDR-TB is significantly increasing in middle-income countries. And malaria is about 50-50 because Africa bears the brunt of malaria, but that's going to be changing. Importantly, non-communicable disease are huge in low and middle-income countries. As you see in the dark blue bars, now non-communicable diseases are higher in lower middle-income countries and upper middle-income countries than communicable diseases, where they've always actually been in upper-income countries. However, a lot of people get left behind, not just the poor, but actually where diseases are going. And that gets back to that last mile. So for HIV, which is a disease we follow on, if you're a female sex worker, a man who has sex with man, or a person who inject drugs, and transgender people are just as bad, you see a massive, massive difference between the general population and their infection rates. It can be 25 times higher. And we've tended to think of this as an upper middle income problem, an Eastern European problem. Not true at all. Low income countries have the same distribution in terms of significantly higher rates than the general population. What really frightens us is the young women, and they are being completely left behind by HIV. This compares the rates in women to men based by age group in different regions of the world. You can see Africa in the middle, well, to the, I guess, your left on the top. Huge difference between women and men. In fact, in some locations, it can be 8 times higher between young women and young men. And it's all based in the same thing as key affected populations, gender inequality. And the reality is we can't have an equal world without gender inequality, without gender equality. So as I mentioned, countries are increasing their own resources. This just shows, and this is from UNAIDS, that for HIV, countries now, low and middle income countries, provide more than half the resources for the response to HIV, more than half. It's 80% for TB, and it's about equal for malaria. But for health overall, the countries have always provided more. The Global Fund's actually got new policies to work with countries to increase their contributions, and just in the last 2 years, we've seen an increased commitment of $5.7 billion for their health systems in the countries we work. And this has led to a notion of global convergence, which is a paper that was published by Larry Summers and others, following up on the historic World Health Report, that shows that by 2040 we could actually have a convergence where people in low-income countries have the same disease rates as people in high-income countries, and that they can finance most of their own health. But it's going to take a lot of work. So that raises the question of who's leveraging whom. A lot of our conversations are how do we as international partners leverage increased domestic finance. The right conversation is how do they leverage us to fill their needs to achieve their objectives. And when you do that, there's a country ownership in a very different way. And if we don't change the way we think and talk, we are never going to get to that global convergence because there'll never be enough money globally. So let's look at the notional direction again and talk about some of the key areas, including innovation, which is what over to the right, where global institutions and international institutions could go as countries are paying for their own health care, as countries are leveraging international resources for their own use. And let's talk briefly about innovation for impact as an exchange of ideas, global public goods, data management and quality, and a focus on a person, not an issue, which I'm ending with because that really drives everything. Innovation, exchange of ideas. We have this horrible paternalistic notion that things that we do globally are taken to countries and that they learn from us, and it's a one-directional approach. Completely untrue. We actually learn more, and they're doing more innovation in many ways than we will ever do. There's a program called ZAMBAM, begun by the University of Alabama. 15 years ago, they realized the programs they were implementing for HIV in Zambia had applicability to rural Alabama, so they brought the lessons from Zambia to Alabama, and it's called ZAMBAM. Thousands and thousands of examples of that, and we need to do it. Global public goods. Procurement and supply chain is one of the most fundamental barriers to countries advancing in health, and procurement systems in particular are very difficult. We have pooled procurement mechanisms that get good rates, and the countries use them, but we need to square the circle. How do countries take advantage of pooled procurement mechanisms when they move past external financing and have country ownership? Answers are usually pretty simple. We basically created something we call eMarketplace, which is an online tool like kayakorpriceline.com, so health commodities will be there and countries can make their own procurement decisions, always getting the lowest possible price, without building a massive procurement infrastructure. You only need a couple people in a room, and the transparency is enormous. They will see the pricing throughout the world, just like you do when you're looking for a hotel. They will know whether or not their regulatory authority approved it. They will know the on-time delivery, and it's pretty hard for there to be misuse of funds, whether it's here in Germany or in Africa, if you can trace every transaction electronically. This type of global public health good, which is different than the traditional sense of global public goods, could revolutionize things. So what are the global public health goods that international institutions should be investing in today over time, which means what do the countries need? What do they tell us they need? And what can we begin to build like the data like this system? Another one is data management systems. And this is what will drive whether or not we have advances in health, whether we're here in Germany or in Africa. And data quality and data management and quality of programs is exactly what health is doing here. You're actually looking for the positive deviance and the negative deviance. Where are people doing well? Where are they not? And then you have that in a data management system. One of our concerns in response to Ebola is everyone's talking about surveillance, which is fantastic. But you have to actually use the data from the individual community healthcare workers to someone in a central level or even a global level. If we don't build systems for individual healthcare workers to collect and use data in real time, we will never have health. We'll have a system. We have done some work with BCG, actually, looking at these positive deviants. Where in a community is someone outperforming someone else in the community, and why? And what we found is that if you just do some simple things, you can actually get 20% efficiency relatively rapidly. And that 20% efficiency means going from 11 people, for example, in antiretroviral therapy to 15 million with the same amount of money, with those people getting quality health care rather than failing their antiretroviral therapy. So using data in real time at the site level with the individual healthcare worker, whether it's a community healthcare worker, a doctor, or a regional manager, has the potential to change everything. When Ethiopia introduced this type of data management into their vaccine system, they actually saw a significant drop within 2 years of the dropout rate in going from the first dose of Penta to the third dose of Penta. You also need advanced technology. So Rwanda, by bringing in a new relatively used TB diagnostic in the same system, went from 1 to 12% effectiveness to 80% effectiveness overnight. So you can use technology, which you also need for data management systems, or you can do efficiency, and you can put them both together for data management and quality programs. Innovation focus on a person. As I mentioned earlier, we cannot achieve any of the SDGs, not just health, but any of the SDGs if we don't have gender equality in the world. So why don't we look at a person rather than an issue? For a woman to have equal opportunity, what does every girl need? And the answer is education and health. And the data are overwhelming on this. We now have data that cash incentives to keep a girl in school can significantly reduce HIV infection, 25 to 60%. Pretty remarkable. What else happens if a girl stays in school? She doesn't get married early, she doesn't get pregnant early, she has economic opportunity, and if she has 92 cents, she will spend, if she has a euro, she'll spend 92 cents of it to clothe, educate, and feed her child and provide health care. Give that same euro to a man, it's about 30 cents. So we need to get to the women. And if we look at how we bring education, nutrition, earnings, economic opportunity together for a person, we can actually have development. But that requires us as external funders to listen to the countries because they've been telling us for years they want us to put this stuff together, and we're going to have to do it. All this means that we have a new landscape, and we need a new vision. We need to focus on people, not issues. We need to look at innovation, and we need to understand the changing global dynamics so that we are responding to the countries to provide services that they want to provide in the highest quality way. If we do that, we will achieve the SDGs. We will actually achieve much more than the SDGs. If we focus on systems, we'll get a system. If we focus on a person and health, for example, we will build the systems that we need for health. That's awfully exciting. It's awfully challenging, and it's a little bit frightening. But it's this type of environment that is ripe for innovation, and we're very excited about where we're all going together. Thank you.
Thank you, Mark, as always, for your inspirational presentation, really setting the agenda going forward. No future without gender equality, and future is all about innovation. So we hand over to Freda Lewis-Hall from Pfizer, a hub for innovation, to see how the private sector is going to contribute to this exciting vision.
Thank you. And thanks to everyone. It's such an honor and a privilege to be here as a part of this important meeting and such an esteemed group of colleagues on this panel. I've been sitting through the program this morning, and almost every word that I'm going to refer to I've heard already in the microcosm of AMBs, but also and AMRs, but also Mark spoke to many of the points that I'll make in terms of the leveraging the life sciences in achieving the SDGs. So in the 1960s, President Kennedy referred to the third millennium. I was too young to understand. My parents did the math, which put me at 40-something. I'm not going to tell you exactly what. In 2000, when we hit the new millennium, that seemed like a very long time. In 2000, when I saw the MDG goals, 15 years seemed like another eternity, but it went by in a flash. So I'm now convinced that what we're setting up for 2030 is going to require our commitment, our collaboration, and we're going to have to move quickly through in order to meaningfully meet those goals. It was mentioned earlier that the pharmaceutical industry, or the life sciences industry in total, had committed itself individually as companies and collectively to meet those. And we've done interesting and provocative things as a part of partnerships, and actually the panel here is reflective of that, from the work that we've done in HIV, TB, and malaria with Mark and the work there, to work with the WHO to advance its goals very specifically to save the children, of which I am a board member of US Save, but to whom we have collectively committed ourselves to on-the-ground work in reducing childhood mortality, in particular preventable deaths in children under the age of 5. And then, of course, last but not least, a recent Pfizer example here in Berlin was a commitment to support the vaccination of 300 million people by 2030, which we believe could prevent up to 5 million deaths. So again, commitment and collaboration. So I'll come back to the theme of meta-collaboration, which is where I think the industry is going in the work in all of these spaces to meet these goals. Briefly, I just want to say, I think that we're going to move back in 15 years and say this was truly a golden age in medicine's development. And by that I mean, if you look at just today, there are 5,000 new vaccines and medicines in development. About 70% of them represent first-in-class work. So this is novel, new technology that's being applied to vaccines and medicines development. A new generation of vaccines that isn't just focused on communicable disease prevention, but also in prevention of non-communicable diseases. Imagine, for example, a vaccine against nicotine addiction, which over the course of this century, if unstemmed, will cause 1 billion deaths. Imagine vaccines that support non-communicable disease work, vaccines against cancers, etc. All of these things are in the work today as we speak in our development pipelines across the industry. A host of new therapies for rare diseases, which a mere decade ago we considered truly rare, and there was not a lot of attention or incentive to work on them. Today, we recognize that about 350 million people are affected by, quotes, rare diseases. So in aggregate, they are not rare at all, and there's a lot of specific work that's being done in this area as well. There's an all-out, wide-scale attack on non-communicable diseases. What we have learned in the war on cancer in the last 40 years are some basic scientific advances that allow us, we believe, to move forward not just in tackling cancers, but to also tackle other non-communicable diseases with great precision. So genomics, epigenomics, metabolomics, proteomics, microbiomics, all of these things are now a part of our arsenal in advancing precision work in the area of non-communicable diseases. And then last but not least, all eyes on researching Alzheimer's, which is on track, unless stemmed, to affect about 75 million people by the year 2030, 15 million in the EU alone. So we believe that there are promising technologies and platforms at work here, and all of this, we believe, will add to, I said golden age, but maybe I'll go platinum on this one, a platinum age in medicine that we'll look back on and say this was it. I want to mention or amplify a point that Mark made, and that is about the interconnectedness between all of the goals. So certainly a focus of life sciences on health goals, but a recognition and respect of the notion that if we're not able to solve all of the issues that deter us from a life of human dignity, education, safe water, justice, food, all of the things that are basic human needs are things that, unless we attend to all of them in aggregate at the point of the person, will be meaningless with all of the high technology that we're able to deliver. So I'm going to focus on 3 priorities that we have as an industry, and this is really a call to action for the collaborations that are going to be necessary to make these not just small scale, but at scale in order to make the differences that we need. Universal access to health care, policies that foster biomedical innovation, and last but not least, breaking down barriers between the work that we do, who does the work, how it's done, and what the focus is. And I'll briefly touch on each of these. I have a friend, this is her opinion, not necessarily mine, but she characterizes it in such a poignant way, I want to share it with you. I always talk about the healthcare system. I'm not much fun at dinners, as it turns out, because I'm always talking about my work. And I talk about the healthcare system. And she looked at me one night and said, "Why are you always talking about the healthcare system? We're not healthy, nobody cares, and it ain't no system." So I definitely don't agree with the middle one. I think a lot of people care, and we're working feverishly to make a difference. But I think the idea that we're not necessarily healthy and the fact that it isn't truly a system, at least not a global system, are probably unassailable facts. But I think that we have all of the tools and necessary elements to make it so. So what do we do with all of that? First of all, I think we deploy the things that we have, simple tools, prevention, education, moves away from crushing poverty and strife, things that make it impossible for people to attend to significant health. We elaborate the things that we have, better uses and better deployment in our supply chain, moving forward vaccines, using education, focusing on prevention, making sure that we have a focus on keeping people above the disability line. Another friend of mine, I seem to have clever and wordy friends, suggests that the elongation of life is spectacular. If you think about 1950, around when I was born, it was 48. I've blown by that, and we're looking forward in 2050 to an aggregate or average life expectancy globally to be 76. She says simply this: we're not really living longer, we're taking longer to die, because many of those years are filled with disability, infirmity, and an inability to fully contribute. So if we really want to make the best of these longer lives, then we need to make sure that people stay well above the disability threshold so that they can continue to live, not just live, but to live healthy lives and to continue to contribute. So if that is what we're actually looking for in trying to accomplish, what are the ways in which we want to do that? So access, of course, is an important way, and financial access is an even more important way. So first we want to deploy what we have, simple tools, cost-effectively deployed to everyone equally, so that the 5.6 billion people that currently use the system when they are at their wits' end or at their health's end, that they're sick and desperate, will now have an opportunity to do so earlier on and in a fuller way. We also have to find unique and different ways to pay for this as individuals and as countries. And there are many ways. We've talked a little bit about how to contribute to programmatic moves, but there are also very interesting things that have happened. Dr. Devi Prasad Shetty, for example, has been doing work in India, leveraging high technology to do incredible work in heart surgeries in children for India. He's done it in an interesting way, systematic changes that allow him to produce and provide these interventions at a much reduced kind of cost, but also has worked with the government to provide a microinsurance policies throughout India so that people have a health safety net, a security safety net that provides them meaningful access to health care. In Mexico, I was just with former President Vicente Fox, who applauds mightily the work of Dr. Julio Frank when he was Minister of Health in establishing a security system for health in the country for governmental and non-governmental workers. So these are opportunities for us to bring kind of Star Wars financing technology to what is currently a Flintstones financing technology platform. The second, just briefly, is really around policy application. Incentivizing through strong policy development ways to advance and support bioinnovation or life sciences innovation. Some of the barriers that currently exist through policy are inadvertent. They were established many, many years ago prior to a need for advances in privacy policies that allow access to big data so that we can do the things that we need. Advances to unique collaborations. Some barriers, for example, exist that prevent public and private partnerships from moving easily forward. These are policies and opportunities for us to create a landscape for the new kinds of collaborations or meta-collaborations that we're going to need in order to continue the pace of biomedical innovation. So what are the silos that we're talking about breaking down barriers to? The first is across stakeholders in healthcare. And I love standing in the middle of a room like this where the energy is just palpable for creating creative conversations and action between governments, academic institutions, private industry, large and small companies, private foundations, individuals, and all of the players in what we understand to be a life sciences innovation ecosystem. So being able to work across these dynamics is really quite incredible. And there's example after example of public-private partnerships, and even some examples of what I call meta-collaborations. One of my favorite recent examples is a lung master protocol. So how do you bring advanced treatments forward for non-small cell lung cancer, just as an example? This was a partnership with patient advocacy groups, with several pharma companies, with the FDA, so regulatories, with the NIH, a government research institution, and academic institutions, as well as community oncology platforms that allow us to move forward in this space. This lung protocol is actually a master protocol intended with this massive partnership to move us all forward, and in particular, patients who need access to precision medicines and non-small cell lung cancer. The second is across scientific disciplines. And this, I think, is especially important at a time when we recognize that some of the solutions that we need in health are not going to come from experts in health. One of my very, very favorite examples is from former President, recently passed, of India, Dr. Abdul Kalam, who was a physicist and worked in rocketry. And he says that of all of the bliss he has ever had, it was using the lightweight materials that were developed in his rocketry platforms and the energy, the precision energy that could be produced inexpensively into the health arena to build joints for babies, lightweight joints for replacement, and to have pacemaker energy sources available that would be affordable to the patients that needed to be served in India. So again, taking things out of the engineering space, if you would, and bringing them into medicine. And we have all kinds of disciplines that we'll need to apply in order to do that. And then last but not least is across sectors. What about the technology and the advances that are made in food, in energy, in transportation? All of these things are applicable in the life sciences, and we need to find a way to tap into them using new resources like crowdsourcing and pricing and gaming and big data and all of the other resources that allow us to apply. I've thrown out a lot of opportunities. I suggest we each pick one, and at the point of opportunity to really build meta-collaborations that ensure that we meet the hardy but reachable goals that we're setting with the SDGs. Thank you.
Thank you, Freda, for your excellent presentation. Clearly, we need more innovation, develop an innovation ecosystem, but also break down the barriers. And I can't think of a better city than Berlin for breaking down barriers and walls. And next we have Nedret to tell us how the stakeholders are going to function in this new environment. What's the new governance landscape look like, and what's the role of WHR?
Thank you very much, Rifat, and thank you for giving me the opportunity to address you on this exciting historic moment where we are transforming the agenda until 2030, where it has huge implications on health. Let me just start with saying that development is impossible without better health, and only the governments that put health and well-being high on their social, economic, and development agenda will be able to overcome the challenges we see facing in the 21st century now. So in fact, health is a political choice. And health is more and more seen also as a precious global good. As you have heard during the opening session, it's becoming more and more of the agenda of the national and international political and social environments. It is becoming more of recognized as a global economic and security issue, but also there's a big recognition that it is a human right. Access to health is a human right and social justice and the underlying factor for equity. And by itself, it's a major investment for human, economic, and social development. At the same time, it is a major economic sector in its own right, where we see in a number of countries it is the cause of the major economic sector. If you look at Europe, we also face the same challenges that the world is going through: an aging population, mobility of the groups, and like the recent refugee movements, health security, Ebola, other outbreaks, and changing epidemiological patterns. And we have to act upon in order to address all these challenges, which requires a new thinking and a new way of acting. And in fact, Health 2020 is the European policy for health and well-being, which has been prepared by WHO in close collaboration with all 53 member states, all stakeholders, civil society, youth, and all interested groups, is very much aligned to the Sustainable Development Goals. It, through its 4 priority policy areas, aims to engage the policymakers across governments and stakeholders throughout the society, aiming to significantly improve health, address the equities, improve and ensure a good governance, and invest through the health, through the life course, and with a strong health system as the delivery forward. Now let me come back to reminding you the process in the post-2015 agenda. As you would know, probably, this was one of the broadest consultative process, and it was not only listening to the opinions of policymakers or the states and governments, but it was really open to all parts of the society, looking at the voices of youth, looking at the voices of people, individuals, disabled, academia, civil society. And as part of that, health was one of the global thematic consultation focusing on what should be the priority for future. I will come back actually on which are included now in the Sustainable Development Goals. And we have gone through a similar process in the region, going through the regional consultation, together with the other UN agencies, again engaging all stakeholders, including member states, civil society, youth groups, looking at what should be the priorities for health in the European region. And there was a consensus that the business for MDGs is an unfinished business. So this should be one of the areas that we should continue to work. There has been a major progress in the region in addressing the maternal and child health, but there is still a huge diversity in and between the countries. And also we are the region with the still highest incidence of TB, particularly MDR-TB worldwide, and increasing trends of HIV. So that has been considered as a priority to continue. The second area has been on addressing the new challenges, like the huge burden of non-communicable diseases, or unaddressed challenges of sexual and reproductive health and rights, or mental health, or substance abuse. And again, there was a consensus that determinants should be the cross-cutting areas, and addressing the root causes on social, economic, environmental determinants should be addressed. And the way to do it should be the Health 2020, as I mentioned earlier, the European Health Policy Framework. So, only 2 weeks ago at the UN Summit in New York, the world leaders adopted the 17 goals and 169 targets, and now we are starting a new era. Some would call it very ambitious, but it's definitely new, it's definitely broad, and it's definitely comprehensive. It's different than MDGs because it calls for an integrated action. It calls for universality, which means it is applicable to all countries, regardless of their development status, developing and developed countries both. Prioritizes fight against poverty and hunger with an equity and human rights approach, and giving special emphasis to women and empowering the women and girls. And also it clearly identifies the means of implementation and also the partnership and resources, as was discussed and agreed in Addis Ababa. So as I mentioned, health is one of the 17 goals, and it's summarized in line with the regional findings. What is new compared to the previous ones is that it also addresses the mental health and injuries and road safety. It by itself has a very strong component on the sexual and reproductive health and rights, but also addresses the determinants of health. And also health security is one of, and natural disasters, outbreaks are taken as a major threat in development. When it comes to universal health coverage, as you have heard from Margaret Chan during the opening session yesterday, that is one of WHO's priorities. Just want to remind you that it is not only access to health care. It is access to prevention, promotion, treatment, and rehabilitation. But at the same time, it's the financial protection to prevent ill health from leading to poverty. And moving towards universal health coverage requires really strong, efficient health systems that respond to the full range of health determinants. It's not going to be only improving the health systems, but also addressing the root causes. And also a people-centered solution while remaining resilient to economic downturns. Before getting into the targets, I wanted to share with you this interesting network, the work that has been done by DISA. What they did is they mapped the goals and the targets and tried to get the linkages between those goals and targets. And some of them are really essential, like poverty, education, and health becomes one of the leading ones. And that's the beauty, and that is I think the power of the Sustainable Development Goals, the new goals, that there is a lot of linkages, cross-linkages and references between the goals and the targets. And if I could give the example of health, health by itself has 9 targets, which is defining under the health goal. But if you look at the one graph on the right side, there are also 8 indirect targets under the other goals, which in a way pushes the work, integrated work, intersectorial work, which is going to be the way to be able to achieve success. So we have a vision now, and we have the global framework. Now it's time to act, and now it's time to put it into the nation's strategies and policies, both in developing and developed countries. Governments will now start integrating the new development agenda into their national development plans. And this provides a unique opportunity to renew the national commitment to public health, through the whole of society and whole of government efforts, and seek intersectorial synergies to advance sustainable development goals. And that requires a new thinking. The universality and the national ownership is important. It is relevant to all countries at all levels, international, national, and local. It requires a policy coherence between sectors and integrated work, and a very good governance led at the national and local ownership, and a whole of government and whole of society efforts. It requires inclusive and participatory approach and partnerships, and mobilizing and using resources strategically. Of course, the other area is the accountability, where the data and monitoring against the targets is going to be an important area. In conclusion, we see the Health 2020 as the key to renewed policy environment. And we have the opportunity to put into practice the whole of government and whole of society approaches addressing the root causes of ill health. And we have a historical political responsibility to pursue the integration of health and well-being into each and every goal. So let's make sure that we are ready and leave no one behind. Thank you.
Thank you, Nedret. Clearly moving forward, achieving SDG 3, but also Sustainable Development Goals as a whole, will require not just joined-up government, but actually an inclusive and participatory process that involves the society as a whole. So it's not just a national plan, this is the plan for everyone. So let's leave no one behind. That's a very important message. So Debra, over to you.
First off, a thank you to the organizers for inviting Save the Children to represent civil society on this very interesting and important panel. Save the Children, we actively engage in global and local advocacy. I lead our office at the United Nations, so we've been very actively involved over the past 3 years in multiple processes that have led to the Sustainable Development Goals. We're committed to engaging children in policy debates, and really where they come from impacts their access to decision-making spaces. Today I'm going to talk about the SDGs and health, and in particular look at moving from implementation to delivery. So we all know that inequalities matter. We all want to live in a world where our children are given an equal start, no matter the country or the family where a child is born. And a world where our hard work can improve prospects and where there's a helping hand for those who need it. Yet we live in a world where from birth, the life chances for some children are so much worse than for others. So the country where you're born, the language you speak, the wealth of your parents, and many more dimensions all determine the extent, the ticket you hold in the lottery of life. So some people from the day they're born have more tickets in the lottery than others. And in fact, this unfair lottery violates every child's right to an equal start in life. So some of my co-panelists have talked about the notion of leaving no one behind. Now, one of the downfalls of the Millennium Development Goals that we saw was uneven development within countries and within regions. So looking at an analysis of data in 87 countries, it showed us that more than 75% of certain children are being left behind due to the lottery ticket they have been born with. Now, on September 25th, 193 children sat in the United Nations General Assembly Hall surrounding Malala as the Sustainable Development Goals were officially adopted, with a vision toward more equitable pathway to progress. Now, among them were 18 Save the Children child delegates who've been advocating for improved child survival across the globe. By 2030, no target should be considered met unless it's met for all social and economic groups. This is the only way to ensure that no child dies from preventable causes, no matter where they're born or who their parents are, no matter what lottery ticket they're given in life. We need to keep people at the center of the Sustainable Development Agenda, especially children and especially the most vulnerable. They're not just the future of our societies, but present agents of change. Now, this concept of reaching the furthest behind first was a huge win for us, and you can't even imagine the battles that we fought behind the scenes at the UN on some of these concepts. So when we look at national averages, we see that there are considerable differences in mortality rates between children within the same country. We also see that countries are reducing inequalities between social and economic groups and have seen overall child mortality fall 6% faster on average over the course of 10 years. So this is a positive trend. So the Sustainable Development Goals. Now, the success of these goals won't be judged by what was declared a few weeks ago, but by what will be delivered in 2030. Now, before September, we talked a lot about the jeopardy of whether these goals would be adopted, in fact. We finally agreed on this agenda. And now what I think is in jeopardy is the implementation. We're talking about an agenda with 17 goals, 169 targets, and this is going to be very difficult to implement in most countries. And when you think about fragile states, conflict-affected countries, it gets even more complicated. It's essential to have a framework that's funded, it's tracked, and delivered in every country for every citizen in peace or in conflict. Now, the overarching ambitions of this agenda to end extreme poverty and finish the job of the MDGs is well-grounded. The multi-dimensional nature of poverty should be underscored to include the importance of raising the incomes in connection with ensuring quality basic services, such as health and education. Now, today's discussion is a great opportunity to discuss how to build effective bottom-up partnerships for the SDGs, especially when we talk about basic services, such as health and education, and that these partnerships can support the implementation of this new agenda. So, over the course of the spring, Save the Children partnered with 8 governments who were keen to look beyond September and look at the practical opportunities and challenges in delivering the Sustainable Development Goals. We held roundtables in 5 capitals with 8 governments: Denmark, Ghana, Mexico, Colombia, Guatemala, Peru, Pakistan, and Tanzania. And the focus of these discussions was on the relevance of the SDGs in their national context. And it was quite interesting. We brought together the negotiators from New York, from their missions, with national staff, with their statisticians, their data people, their various ministries, to talk about the national reality. We talked about the importance of engaging civil society and ensuring that processes were transparent, and engaged a broad sector of stakeholders. So a couple of the highlights from those discussions include the following. First off, we must see action to inspire action. Delivery is a critical ingredient in the post-2015 narrative. So in September, we had leaders making commitments for how they will deliver the Sustainable Development Goals at national and international levels. And again, I want to underscore here that civil society has a critical role in implementation as well as accountability. We at Save the Children made a commitment that in 2016 we'll invest $250 million in our global health and nutrition work, focusing on the poorest and the most marginalized children and their communities. And in fact, we're working in a lot of places where it's even challenging for the UN to be working. So we're contributing to strengthening health systems, helping to deliver life-saving programs, and including in humanitarian settings. A second issue that came up in these discussions was delay will be costly for this agenda. So my co-panelists talked about the urgency of this agenda and how quickly these timeframes do go by. And that on January 1st, the deadline for the Sustainable Development Goals will just be 5,000 days away. And this is really very little time to achieve goals that require unprecedented improvements to business as usual. The world can't afford a slow start. There was a slow start with the MDGs. If delivery is not well underway in the early years of the new agenda, if the financing's not there, many of the targets will be already out of reach. So we need to learn from the MDG process and cut the time lag between adoption and action. Civil society can call upon their governments to start the process and engage them in planning for implementation. So this is what we're doing. We're starting this conversation even before January 2016. A third issue that was highlighted in these roundtables is that we shouldn't be afraid of priorities. So in the end, the distinction between the indivisible aspect of the SDGs and the need to set priorities is a false one. No country can do everything at once. All stakeholders must set out where they plan to start in order to provide a foundation for accelerated delivery of the agenda as a whole. Fourth point that came out was that we need to think for the long, medium, and short term, and that countries really need to plan for these 3 time horizons. And this is something that we advocated very strongly on during the negotiation process, and in particular when talking about reaching the furthest behind first, have been encouraging governments to look at what are some interim targets that they can set. And then finally, children have the right to be heard. Paragraph 51 of the outcome document says that children are agents of change. And we're advocating strongly for children and other civil society members to be involved in developing, implementing, and monitoring the laws and policies that affect their lives. My final point is on accountability. One of the 18 child delegates, they were all extremely articulate, ages 14 to 18, and one young woman from Sierra Leone, Miriam, was in a BBC radio program with Amina Mohammed and Helen Clark, and right off the bat she asked the first question to Amina Mohammed, and she said, my people don't know anything about these Sustainable Development Goals. Can you tell me exactly how you ensured that my government was a part of this discussion? And can you also tell me how you're going to ensure that my people will be aware of this agenda so they can make sure their government follows through? So national accountability between the state and its citizens should be the bedrock of the post-2015 accountability, with countries conducting regular reviews of progress in an inclusive and participatory manner. And that means including children and youth. Children and youth were actively involved in consultations to develop these goals. And in fact, during the governmental negotiations, the government of Netherlands shared the outcome, and that was utilized as a particular ongoing reference tool. Save the Children, together with the International Confederation of Midwives, the UN Foundation, White Ribbon Alliance, the World YWCA, and World Vision, another commitment we've made is to support and strengthen civil society constituencies, including health professionals, women, and young people, to hold leaders to account for their promises and build pressure and demand for the realization of the global strategy for women's, children's, and adolescent health. At the global scale, an open, inclusive, and participatory high-level political forum, which will be the mechanism that is tracking progress on the SDGs, needs to provide reviews of national and global processes, allowing us to assess progress on the implementation of the SDGs. And we're advocating to also include peer reviews of national progress. And finally, it's key that accountability should consider progress or lack thereof for the most disadvantaged and marginalized groups. And that's why it's particularly critical that there be extra support to ensure those groups of people be at the table to share their experience and be a part of this monitoring process. And they need to be a part of this process because we want to ensure that we do not leave anyone behind. We want to make sure that no target is considered met unless met for all social and economic groups. So in conclusion, this has been a year of extensive consultations on the development agenda and financing for development. The clock is ticking. What will you do to ensure that ambition leads to participatory development? We all want to live in a world where our children are given an equal start, no matter the country, family, where he or she is born. Save the Children remains committed to thinking beyond declaration to delivery, and I look forward to hearing about how you will look to translate political endorsement of the agenda in September into practical national implementation. Consider us your partners on this journey. And I'll leave you with a quote from a 19-year-old woman from Somalia. She says, "You know, there are rules and laws and regulations set up by the UN. There are conferences and meetings held where decisions are made. Where does this all end up? Let this all not end up on paper. Let it go through to the people, which I think is not a difficult job. Let people know their rights through whatever you come up with so they can fight for their rights." Thank you.
Thank you, Debra, for very clear messages and inclusive process with accountability. I think for me, with the HIV movement, and Mark will remember, one of the most powerful calls to action was nothing about us without us. And I think we need to ensure that this happens with children and women, but especially the vulnerable populations and those who are disenfranchised. And I think this is a very good moment to move to Dagfinn for his comments on how to reach that remaining, the last 20% or the last mile. Tell us.
Thank you very much, Mr. Chair, and thank you. You've been a patient audience listening attentively throughout this panel, and now comes part of doing the stuff, ensuring that sustainability becomes action and not sustainable. First of all, I must say that you've had an historic celebration here in this city the last few weeks. And we're also here from Gavi to celebrate Berlin, because in January, as many of you know, we made the case to the world leaders to finance immunization for the poorest countries of the world and the poorest people of the world here in Berlin. And the response was fantastic. In the midst of a financial crisis, the world leaders under the championship of Germany and Chancellor Merkel stepped up to the plate and granted Gavi the targeted number of billions of dollars, $7.5 billion, making Gavi available and able for the next period up to 2020 to achieve what we here are talking about, reaching the fifth child and increasing coverage and equity in immunization. Let us look at what we have achieved together so far. 500 million children have been immunized. 7 million future deaths have been averted. This is a story that really has changed the world already. This is a story that has changed the lives of these children, their families, their villages, their nations, and eventually the world. So immunization is a powerful tool in public health, but it's really also a powerful tool in changing the world and building the backbone of the future generations. What is Gavi's contribution to the Sustainable Development Goals? What we asked for in Berlin in January and what was granted us was a huge vote of confidence to immunize another 250 million children and by 2020 save another 5 to 6 million lives, avert more than 100 million illness cases, and not to forget the economic part of it, to avert costs related to illness in productivity loss, treatment costs, caretaker productivity loss, transport costs, and so on, 80 to 100 billion US dollars. Look at this, what you get for 7.5 billion invested in this public health intervention and the system around it. It's really a very, very powerful investment. I want to make the case here for a separate vaccine indicator under the universal health care goal. I think you are well aware that if the global goals are to achieve what they set out to, the next few weeks will be crucial. An UN expert group will need to try to agree on how to measure progress and success or failure, as many of the panelists have touched upon already. Each of the 17 goals is made up of several targets, 169 altogether. Global goal number 3, for example, to ensure healthy lives and promote well-being for all ages, includes a target to achieve universal health coverage. And a true indicator of universal health coverage, in my view, should be an intervention that every country can readily measure, that speaks to the equitable access and quality, and that will reliably ensure the health of a population. Immunization is such an indicator. That's why some voices, including that of Gavi, the Vaccine Alliance, are calling for the Global Goals framework to make full childhood immunization a separate and ambitious indicator of the universal health coverage in its own right. Listen to this. More than 30 vaccine doses are administered globally every second. More than 30 doses every second. No other health intervention reaches so many people or is capable of preventing such a diverse range of public health concerns as immunization. And at the same time, it helps to identify worrying trends in rich countries, such as the drop in immunization in parts of the developed world. In California, for instance, levels in some districts of California, it levels on a par with South Sudan, which has led to outbreaks the recent years. So, This is, I think, an important detail, but not so much detail, after all, when you look at the figures of what we have achieved through the last 15 years. Let me also mention the example of Ebola. Speaking of outbreaks, in the past 18 months, we witnessed the collapse of health systems in Ebola-affected countries. Ebola ravaged already weak health systems, disrupting routine health and immunization services throughout these countries that were affected. In, for instance, Guinea, in 2014, approximately 150,000 children did not receive the essential vaccines against polio, whooping cough, tetanus, measles, and yellow fever. Almost 40% of the 400,000 children targeted for routine immunization in the country were not reached in this year. And the global response of temporary emergency management has been successful, but now longer-term support is needed to rebuild the effective systems sustainably to prevent further crisis. This case illustrates the importance of not only focusing on immunization as such, but on the routine immunization systems as a part of a broader public health package and as a part of the total health system. Gavi is supporting this process and is investing in rebuilding health systems, as well as we are working towards making new Ebola vaccines available to developing countries at affordable prices once they become available and WHO recommends them. Let's look at the issue of health system strengthening. Gavi is increasing its support to health system strengthening, and in relation to this, I would like to congratulate Germany on recently making a bold commitment for strengthening health systems in Africa, committing 600 million euros over the next 4 years for the implementation of Chancellor Merkel's 6-point plan on pandemic preparedness. This is a strong signal with which Germany will remain a champion in global health, as it started off this year so wonderfully by leading the G7 and leading the replenishment of Gavi. Successful partnerships between, for instance, in this case, the German Development Bank, Gavi, and the East African Community is one case of how we are trying to ensure this focus on health systems. National policies in order to address the correct aspects of audiences depend on quality data and surveillance. At Gavi, we understand that strong immunization services function as an extra point into the wider health system. Imagine this. And I've seen this in country after country. In the process of vaccination, within the first year of a child's life, each child, together with his or her caretaker, it's usually the mother, has on average 5 contacts with the immunization part of the primary healthcare system. This means they have a chance to make contacts with the health system. Children are registered. A basis for their existence in governmental records is being achieved, a basis to collect data, and that in turn will inform countries' health systems and will feed into planning of needs and budgets. This is an example of how immunization really drives a wider public health package and is so essential in developing health systems. At Gavi, we see our focus on health systems as complementary to what other actors do, other partners like Germany in this case, and we're happy to have concluded a solution with Germany on establishing and the East African Community on establishing a regional center of excellence for health supply chain management in the East African Community in Kigali, Rwanda. This center will build capacity for health supply chain management and professionalized health supply chain systems, and it will contribute to the mentioned implementation of the Chancellor's 6-point plan. Just to remind you that Gavi's resource mobilization model is like a 3-legged stool with the donations, with the co-financing of the countries themselves, and with market-shaping activities, and we are currently exploring opportunities for engagement with the German private sector, that will aim to create efficiencies and cost savings in country vaccine supply chains. Gavi seeks to increase in order to increase access to the latest innovation and expertise in the areas of supply chain, data quality, demand generation, and in order to create cost savings for countries and increase vaccine coverage and equity. And this whole idea of countries taking ownership is going to be a mark of the next strategic period up to 2020 for the Gavi alliance. All the 73 Gavi-supported countries are co-financing a share of the cost of new vaccines. And their share increase as their economy grows. And eventually they will transition out of Gavi support, but will be able to obtain reasonable prices based on the Gavi model. And what we see is that this is a very important part of ensuring sustainability of immunization services, and it will require new tools and approaches, especially as country transition. Since July, Gavi has a new graduation and eligibility policy to ensure that all countries can build successful and sustainable health systems that will take the economic growth experience of each country into consideration. We're looking forward to implementing the pledges that were given here in Berlin in January, including the pledge of Germany. At Gavi, we focus on lean, transaction cost low models for implementing donor funding. And to keep the Gavi model well run, with low overheads, we need our grant activities to keep administrative costs low. This is the core principle of Gavi's business model, and this allows us to give the vast majority of our funding, more than 97.5%, to the children who need help, and keep our administrative costs to a bare minimum, less than 2.5%. As we are implementing the pledges of this year, this principle of cost efficiency is a very important one for us. To conclude, the strategy we at Gavi has now been able to put into implementation because it's funded and it's supported by all the partners, many of you present here in this room. We will build on the tremendous results of the last 15 years. As I mentioned in my introduction, 500 million children vaccinated, 7 million deaths averted. Thanks to your involvement, particularly in the past year, which led to Germany's support in January, we're now able to vaccinate another 300 million children up to 2020 and to avert another 5 to 6 million deaths. It's about health systems, it's about declarations and agreements, it's about innovation, it's about technology, but it's, as many of the panelists here have underlined, it's about the people, and for Gavi it's about the children. And I will end at that note. I was sitting summarizing my public life, writing a book. I was Minister of Health and all the experience I'd done, and then my 6-year-old granddaughter came up on my lap and she asked me, "Grandpa, what are you doing?" I said, "I'm writing a book." And she says, "What is it on?" And I said, "It's on what Grandpa thinks is the most important in the world." And I asked her back, "Do you know what that is?" And she said, "Yes, that the children may live." That's the core of my message. Thank you very much.
Thank you, Dagfinn. Impressive achievements by Gavi and a very powerful note to end on. And I think Gavi, as with Global Fund, are examples of these inclusive partnerships that have really translated policy and ambition to action with so many lives saved. I said 12 minutes and my speaker has kept to 15 minutes, so thank you very much for keeping to time. We have 10 minutes for taking some questions from the floor. And we have some microphones, and please stand up and announce who you are. Keep your interventions to questions, not major political statements. Questions so that my panelists can answer. Thank you.
Thank you very much. My name is Amir Takian from Tehran University in Iran. Thank you very much for a very insightful presentation. I have two questions, perhaps for the all panelists, but specifically for Mark and Freda. My question to Mark is, you mentioned about changing the focus from the systems to the people. This is very inspirational, but in practice, how on earth we can, what are the practical mechanisms in order to reach that kind of a strategy when you don't have enough and a strong health system in place and a stable political system in place that somehow prioritize people? So could you shed light on that? And for Freda, I would like to have your opinions, especially in the private sector. For one of the pillars of SDG perhaps can happen through the new medicines, as you said. And what is Pfizer's strategy for AMR and the way that you're dealing with that in your company in order to contribute to the achievements of SDG? Thank you.
Okay, Mark.
So thank you for the question, and I think this is a key question. I mean, everything I talked about was actually related to a system. But if you focus on a system, you're going to get a system. If you focus on a person, you'll build a system that relates to delivering for that person. So just linking health and education as an example, we are now working in a number of countries with the Global Partnership for Education, with Ministries of Social Development, Education, Health, and Finance to put together a package. So a health program isn't going to fund a lot of education programs, but we can link together so that there's a package that is provided to a person. We can do this within health. So we've combined with UNICEF, for example, to provide integrated case management, and the World Bank, actually. We provide a piece of it, they provide, and each of them provides a piece of it, and the country provides a piece of it. So we can spend probably the next 15 years arguing about radically changing the global architecture, and maybe that should happen. Or we can actually partner in country to support the country to put a combined approach together. And that's the approach we're taking, whether it's within health programs, and we do this with Gavi too, or crossing sectors. And that is difficult because ministries are established in certain ways, and we're all established in certain ways, but it's actually quite possible, and we're showing how it be done so that you don't take health money and put it in an education system, but you put it all together in a community.
Freda?
And then I can't resist commenting on this patient or person centricity from an industry standpoint. Some of you may have noticed that within the pharmaceutical industry, large and small bio, we've started to establish offices and a focus on how to engage actively with patients and their advocates and caregivers around what actually needs to happen to deliver meaningful health interventions in the form of medicines, diagnostics, and devices, and to use that information to develop endpoints that would be validated with the scientific community, that we would advance new technologies to meet those needs. So I think that patient centricity, not just in services delivery, health services delivery, but also in delivering new tools to those health service deliverers in the form of new medicines and interventions, is something that we're shifting a focus on to the center of our universe, our North Star, which is patients. And then to answer your second question around, and I'll do the industry if you don't mind with the little Pfizer, and that is Pfizer is actively involved, if you would, in, I'll call the spectrum of responsible utilization of antibiotics, which is a key part, as you heard this morning, in this space. And also our work in vaccines is quite notorious. And again, so two, we think, important elements. And we work collectively as a part of the entire ecosystem around antimicrobials, including things like unique JVs to meet specific needs like HIV, like multi-drug resistant TB, et cetera. So I think that you'll see that industry kind of is named as a player in a lot of ways, and Pfizer specifically is very active in this space.
Thank you. We can take two more questions from the floor. Yes, at the back. And please, just
my name is Paul Kleijers from the University of Zurich. I was somewhat surprised that the entire session almost exclusively focused on Africa. I mean, Africa everywhere, is that the only patient? Are there other areas in the world that have interrupted the vaccination chain? What about the sub-Indian continent? What about rural areas in South America? Are they not on the agenda?
Well, I think Nedret talked about Europe and Mark talked about the middle-income countries, which clearly include China and India. But and I think the focus was exactly. So I think we had a global focus, although it may have appeared as Africa. So maybe, if there are no other questions from, yes, one other question, yes.
Hello, my name is Kajsa Lindberg. I represent Ung Diabetes and IDF's Young Leaders in Diabetes. I would just like to hear your thoughts about the fact that in the SDGs there's a lack of focus on obesity. Well, we know that today obesity is a huge risk factor in NCDs, in particular type 2 diabetes.
So, Nedret, I'm going to ask you because I know this is part of Health 2020 vision.
Well, the risk factors constitute a huge part of the challenges and addressing the non-communicable diseases. So I really take it like in order to be able to address the non-communicable diseases, you have to also tackle proper diet, physical activity, which is going to be leading to tackling obesity. So we will probably see those more in the indicators, but as we take it, it is as part of the NCD package and through the risk factors.
Yeah. And critically, WHO, the World Health Assembly has agreed on 25 by 25 targets, and obesity is really at the center of that. Any other questions from the floor? If not, I'll use the chair's privileges to ask my panelists a question which each of them can answer maybe within 30 seconds. What is the biggest risk? So here's a very ambitious agenda. 17 goals, 169 indicators. And I should remind you, we have a test at the end of this session. We're going to ask you if you can remember those 17 goals, 169 indicators. Okay? If you can get 10% right, that would be great. So what's the biggest risk in your view?
The biggest risk is we don't change the way we think and operate. If we try to achieve the SDGs in the way we achieved tremendous success over the last 15 years, and I should have pointed out the Global Fund supported programs that have saved 17 million lives, extraordinary progress. But if we continue to work in the same way, we will not achieve the SDGs, we will not have healthy people, we will not have development.
Excellent. Freda?
I think it's continuing to work in silos, not collaborating, which leads to gaps and redundancies and waste. So I think, I hate coming after Mark because he always kind of speaks my mind, but I think silos and the way that we've worked previously is certainly a risk.
Okay.
Well, obviously, the two areas was my priorities too, but I'm just building upon. I think I will call for people-centeredness and adjusting the interventions with the people's rights and human rights and equity approach. The second part I would say is engaging the whole of government. Intersectorial work is going to be crucial.
One risk I see is a lack of progress for the furthest behind. And then a second, I would say, is excluding civil society in the monitoring and accountability processes.
It's a very exciting time for the world because the economic development of the South really makes it possible to reach some of these targets beyond what we had expected just a few years ago. But the risk is that we're not able to match the rights, the social rights part of this agenda with the obligations on the governments and on the citizens. So that if there is not a social contract underlying this whole concept, I think it's a high risk that it will fail. But keeping that in mind and not be afraid of prioritizing, I think we can achieve.
Great. So maybe to sum up, clearly messages are more innovation. More of the same will not do. We need to think of new business models and new ways of doing business. And then avoid silos, have an inclusive process beyond governments. Civil society is key. Ensure equity agenda is achieved, and ensure social rights through a process where everybody is responsible in the design, implementation, delivery, and accountability. Please join me, everyone, in thanking this outstanding panel for their contributions.